So with that, we have our first panel up here today, which is an incredible group of leaders from a variety of government entities here in the U.S. that are all making a difference. Coming down the list here, I've got Dr. Foster Geston, who is the former Chief Medical Officer for the Office of Quality and Patient Safety, New York State Department of Health, and co-chair of NSepsis, National Sepsis Expert Panel. Been working very closely with the Stoughton family, others not in this room, and with Senator Schumer's office on some of the items like Senator Schumer talked about before. Next to him, I have Dr. Robert Valdez, who is the director of the Agency for Healthcare Research and Quality. I'm not used to spelling it all out. We know it very happily as AHRQ. Next to Dr. Valdez, I have Dr. Denise Cardo, who I've known for quite a while. Kieran, Orla, and I had the pleasure a decade ago meeting Denise in Atlanta at CDC headquarters when Senator Schumer set us up for a meeting with then CDC Director Dr. Friedan, which began this journey with the CDC. And I want to applaud Denise and her colleagues on the sepsis initiative just pushed out for hospitals just 2 weeks ago. And then last on the line here, and certainly not least, is Dr. Ron Klein, who is the Chief Medical Officer of the Quality Measurement and Value-Based Incentive Group of Center for Clinical Standards and Quality at what we all know very well by its abbreviation, CMS, the Center for Medicare and Medicaid Services. I just want to thank you all for being here. I think, Dr. Geston, you are starting us off here?
I am.
Very good.
I will.
Thank you much.
Do you have some slides? There we go. Well, good morning. What an honor to be here. I can't think of a better lead-in than what Dr. Tracy described in terms of the need for a multiplier to go from what one area, one state, one health system has done to multiply across the state, across regions, across the country, across really all borders. And so I've been asked to start that conversation off and really describe what we think is the imperative for a federal role to play, to be able to help in that multiplier effect. And I think the news is good, and I think that we're on the path, but as he described, we have a lot of things to do. So I'm going to talk a little bit about our New York State initiative, which has been referred to very briefly, very high level, really in order to set the stage for what we see, how we see that as a springboard for that multiplier, for that larger effect. I'm going to talk about our working group and what our goals have been and our process, what we have done to date, and really leave you with a bit about what's next, which will echo, as you'll hear, some of Dr. Tracy's comments. And then really setting the stage for our great panel here to talk about what they are doing, what their goals are, and what their next steps are. So our overarching goal that I think, despite controversies that exist in clinical care always, I don't think there's any controversy that we agree that the care that patients receive should not be by chance or lottery or just depend on where you walk into at a particular time or a particular hospital, but based on evidence. It should be systematic, it should be team-oriented, and it should recognize this critical role of time in the diagnosis and treatment of patients with sepsis. We don't have to invent a new way of thinking about time-dependent treatments. We have several models, and we have models for care of heart attacks and stroke and trauma care as well, in which we've not only had a national initiative to alert people to what the signs and symptoms are and what to do, but we've also built systems of care. We've built centers of excellence. We've dealt with the way in which hub and spoke hospitals can relate to one another to ensure that people get the highest quality care no matter where they enter the system. And I would submit that really what we're looking to do is to think about how we have a parallel model for that for sepsis as well. And again, we have experience and we have some infrastructure to do this. Our initiative in New York, started a long time ago, it seems now, was certainly animated by Rory's untimely and tragic and preventable death. But I would also say that we recognized at the time that there were existing quality improvement initiatives directed at sepsis and research going on that we could work on, that we could build off of, although those initiatives were voluntary. As we started to dig into this, saw variations in care and the way care was delivered and the outcomes of care that we viewed as being unacceptable. And we were also obviously supported by our political and agency leaders, both in the governor's office and Senator Schumer's office, as you heard, and also in the Department of Health. And that helped enormously to have that executive branch support and leadership. Let's see. Our process of going about doing this could not have happened without a large team and a large amount of collaboration, which we would submit is still critical given the complexity and the number of things that need to happen at the same time. So our clinical community, hospitals and hospital associations, families and patient advocates, and also we relied on national expertise, some of which is here in the room, as well as our homegrown expertise in New York State. There's been a lot of, I think, confusion or mythology about what the regulations, Rory's regulations actually required. And over the years, we've taken great pains to talk about really how basic the regulations really were. And this is what they were. It was to ask hospitals to formalize, to create formalized guidance. You can call it an algorithm, you can call it a protocol, you can call it practice guidelines, call it whatever you like, that would direct and inform how clinicians were going to do an early diagnosis and treatment of sepsis patients, both adult and pediatric. And while we urged and required that that be based on current consensus evidence, we also created some flexibility, understanding that hospitals had to implement these things in different ways based on what their resources were and how they were constructed. We also asked hospitals or required hospitals to train staff on these guidelines and protocols so that they were not just something that sat on the shelf. And then next we asked that hospitals submit data to us so that we could see and they could see, well, this is what you said you're going to do. Did you do it? And how well did you do it? Pretty basic. Adherence rates. And then we also wanted to look at outcomes. So not only how did you think about the care that you wanted to deliver, whether you delivered it or not, and then to what effect in terms of patient care. We had an open invitation to the hospitals and associations to participate in advisory groups. Our work was public and transparent. And we kept to our North Stars and our mantra, our ways in which we deliberated, and the things that we agreed on was, again, survival depends on rapid diagnosis and timely treatment. We made a commitment to not try to get ahead of the science, but we also committed to not ignore the science and ignore what we knew worked in this high mortality condition, which was sepsis, septic shock. We recruited experts, listened to them. We understood and tried to work through controversies and differences of opinion, which happen all the time. We committed to public reporting and accountability, including public reporting about our own initiative and the degree to which it was effective. We also committed to feeding back the information, the data that we were collecting to the hospitals on a regular basis, on a quarterly basis, compared to other hospitals in the state, so that they understood how they were doing. And this was really critical and I think well received. And we tried to be mindful of unintended consequences and to look for them. We had a lot of concern about whether or not promoting early use of broad-spectrum antibiotics was going to lead to further problems or issues related to antibiotic resistance and overuse and so on. And we were mindful of that and looked for it. And as some folks may talk about in later presentations, thankfully, that did not come to pass. We adjusted and asked, demanded of us and of the hospitals to modify and change both the guidance, the protocols, and their processes of care based on those outcomes. So this is not a static initiative, never should be, wasn't intended to be. Our very high-level findings, and you heard Kieran talk about them. We saw a tremendous amount of variation, pretty much everything that we looked at. Not surprisingly, we found that while clinical controversy certainly exists now, exists always, particularly at the time there was a tremendous amount of controversy around central line, use of central lines in management and fluid management and so on. But we also found that there was tremendous agreement about early recognition, about early antibiotics, about blood pressure support and so on, things that we could do and do on a more systematic basis that save lives. We saw improvement over time in both processes and outcomes in the data validity and measurement, and we saw much to our satisfaction that when our initiative was evaluated in terms of the level of improvement compared to the background improvement that was going on nationally, that the rate of improvement in New York was greater. And that was very important validation for the work that we were doing and the way in which this kind of focus work could really make a difference. Lives were saved. This is just a subset of some of the literature and the articles that were done in peer-reviewed literature to look at our initiative, to use our data. We worked with outside folks so that the validity of our findings and the accuracy of our findings was high. So that was a starting point. But really, how do you go from one state, and you'll hear about another state, you can hear about Michigan as well. How do you go from there to dissemination on a broader scale? It's not natural. It doesn't happen by itself. The levers of a national initiative are different than they are for a state or a region. And so our challenge in our group and our collective challenge, I would say, to this group of interested folks is how do we actually do that? How do we do that multiplier that Dr. Tracy talked about? Our goals, as we think about a national initiative, are as they were in New York, as I assume we agree on, is the notion that care should be excellent anywhere, anytime, for everyone. Our current reality, based on data, is now a few years old, but I doubt it's changed dramatically, but I'm willing to be corrected, is that based on the current measure that's used nationally, SEP 1, you have roughly about a 50% compliance with a set of interventions that have been found to be effective in helping people survive sepsis, 50% with wide variation. So essentially what we saw in New York, what you see when you start to look. We think it's important as we go forward to ensure the inclusion of pediatric and maternal sepsis as well as we start to think about our initiative, both in terms of measurement and interventions, and address disparities that exist, whether they're based on race, ethnicity, or geography, or income, and so on. Our goal is really to, without bias, to spread and replicate and advance and support what works. And New York is offered as an example. It was sort of our starting point, but we know that there are initiatives that have happened in other systems, in Northwell and Kaiser Permanente. We know that the Institute for Healthcare Improvement, AHI, has led initiatives in surviving sepsis. We have the Surviving Sepsis campaign itself. You're going to hear about Michigan. We know a lot about the kinds of initiatives and what needs to happen for this sort of spread and dissemination. We just have to do it. We have to invest in it, and we have to work at it. Our orders are basically to have a coalition of the willing, but we also have, I think that I can say that we have continued to have conversations, I wouldn't say with the unwilling, I would say with the reluctant or folks who have other priorities. As we all know, the world has been understandably preoccupied with COVID these past few years. Most of those deaths are deaths from sepsis, by the way. But we have continued to have conversations with all the national organizations and leaders across the country and internationally that we think can be helpful in this initiative. collaboration we understand, particularly across federal agencies, as they were in state government, are not natural events. We don't assume them. We have to work at them. We have to make those happen. And obviously, the clinical community, the science, our patients and families are critical to making this all happen. So we have some specific goals and achievements. Kieran referenced some of those in the omnibus bill, in which we got some funding and some language, a great beginning. You heard people talk about the statistics of what we know about mortality, what we know about costs related to sepsis, but you also heard Dr. Tracy talk about all the things that we don't know about survivors of sepsis, about morbidity. So we thought our group believes that it's important that we better understand the scope of the human and the financial impact of sepsis in the United States, particularly with the goal of helping us ensure that our investments and the work that we do match this burden, which we don't believe does yet. I mean, I think if you haven't gotten that from what we've said, I think that there is a firm belief that we have a long way to go. So we are, thrilled that ARC has embarked on this the study. You'll hear more about that when the panelists speak. Looking at outcomes that include mortality, that include hospitalizations and readmissions, long-term care, the impact on public insurers and taxpayers. But we also want to get a better sense of what's the opportunity to save lives and save resources if that variation is reduced, if that level of care that we seek that can be improved happens not just in New York, not just in Michigan, not just at Kaiser Permanente, not just at Northwell, but across the country. And we think that that's large. We've also, and you'll hear about this, and we're thrilled about the standards of care, the formal guidance, the core elements that CDC has recently announced. We think that that is a huge step forward in terms of providing some of these structural and suggestions for how hospitals can put their systems together to increase the likelihood that high-quality sepsis care is delivered. I think that those core elements, frankly, go beyond some of what's in the structured requirements in New York for hospitals to put things together. So I think it's a really great step forward. But we need to work and make sure that this, there's oversight that this actually happens, and that there are resources to help hospitals across the country be able to implement these. We see, a number of roles in doing this for the Joint Commission, for CMS, for CMMI potentially, for the Institute for Healthcare Improvement, and any others who are willing to sort of join in this. We also see a need for better measurement of sepsis beyond SEP 1, which many of you know has been as all measures are, imperfect, but maybe this one a little more imperfect than others, certainly highly controversial. We think that that controversy and that single measure should not stop the movement forward to create better measurement. Again, we don't have to completely reinvent the wheel. We have some of these in New York and other places have been using measures, including outcomes like survival and mortality, readmission, and so on. We think that they should include pediatrics and maternal cases of sepsis as well, and the language in the omnibus bill, requires CMS to take into account the measures that were used in New York and consider the National Healthcare Safety Network, which CDC has been using for surveillance and QI related to hospital-acquired infections and other conditions. We have a lot to do next. We're supporting resources to actually put improvement and put these structures in place is still an open ask that is on our agenda for going forward. Promoting family and patient sepsis awareness. Could this be sepsis? Again, harking back to campaigns that have been successful for other diseases. We know that we can do this. We know that we are doing it. We can amplify that effort. Our goal is to have an investment that's commensurate with the burden and the opportunities at hand. And that includes areas of prevention within the hospital, but also outside in the hospital, in community and outpatient, and even home care and long-term care settings. The need for better tools for early detection, better therapeutic approaches, as was talked about, including maybe particularly for viral sepsis as well, as we saw with COVID, and then reducing and starting to address and better understanding the morbidity risks that are associated with survival. So thank you for your attention. I'm going to turn it over to the next speaker and look forward to the discussion as the day goes on.
So Dr. Cardo, you have some words for us? Please, thank you.
Did they put my slides? Or? So good morning. It's okay. It's a pleasure for me to be here, and thank you for the invitation once more. And since I know that it's being also, there are several countries joining, including Brazil, I just want to say bom dia a todos os colegas brasileiros e que aprendam bastante para fazer uma diferença no país. Can I have my slides, please? No. So why we're here? We're here because of all, and this is just a very small sample of all the people who have been impacted by sepsis. That's the reason we're here. But we're here because I don't want to add any more pictures to the slides. So that's the reason we're here. So CDC, I want to say a few words about what we've been doing, and you heard, especially in the last 10 years. Before that, it was more prevention of infections. And we thought about sepsis, but we didn't think about our role in sepsis. And thanks for working, because of all of you, especially the Stontons coming and really questioning, can you do more? How can you do more? We moved from just having projects or publications to having programs in which they are based for data for action, innovation, education, and collaboration. And collaboration is the critical point that you're going to hear from all of us. So how did we do that? Initially was how big is sepsis? How big is the problem? And as you heard before, there was a lot of problems. What is the definition? And we decided, let's put together a group and let's decide a definition for surveillance, at least to address how big the problem is. And that's when we published this, what we call vital signs. And we saw that sepsis, although we're talking about sepsis in hospitals, most of the sepsis patients came to the hospitals with sepsis and were not recognized at that point. So we really needed to look at the problem across. But also, we were able to estimate, and we hope to update this estimate soon. Those are numbers that everybody's talking at this event. But I want to highlight this is just for adults. It doesn't include kids. But the main thing I feel that we were able to do together at that point was not just to put a number that people can show how big it is, or also to talk about the spectrum, but it was saying that sepsis was a medical emergency and really needed to have actions. People need to take actions not just in the patient level, but in all different levels. So it includes also public health importance. So in addition to that, it was very clear people didn't know what sepsis was. So we worked with several of you to really start an educational program, not just for patients and families and communities, but also for people working in healthcare. Because we learned that we have people who are they were attached to the definition of sepsis, but without knowing exactly what they had to do. They had to think about sepsis. Even if they didn't know how to define, they need to know how to think about sepsis and act. So that's when we really start this campaign and working with several groups. And it has had a lot of, it's not the campaign like tobacco, that is, because we had no money. So we had to do whatever we were able to, but at least it was a way to really be vocal and have people using the materials. So today we heard some successes, and I'm so happy that we're hearing successes. We heard that if there is an early detection, the person can survive. Early detection with appropriate management. We heard from Northwell that if you implement those protocols in an institution or a network, it makes a difference. We heard from New York that when you do that in all hospitals, it makes a difference. So, and nothing is perfect, but it's good enough to really make a difference. And then that's what we need to do. So when we thought about, okay, how can we move forward in conversations with many of people here, right now we don't have the ideal metric. How can we move forward to make a difference and from all these lessons learned? So that's when we thought about having those hospital sepsis program core elements. And you may think, why did you do that? We did this for improving antibiotic use. And it was a big thing because we worked with CMS, we worked with Joint Commission, worked with hospital associations, and we saw a major improve in the programs for improving antibiotic use. So, so we thought, let's do the same thing because we know the core elements that are critical for really hospitals to prevent, early detection, and manage sepsis. So those are the core elements. And you may look and you think, oh, they are so easy. Like, what are you talking about here? Is hospital leadership commitment, accountability, and if my slide come back, multi-professional expertise, action, tracking, reporting, education. But guess what? We have specific examples of what needs to be done. And this includes, especially for the accountability level, need to have goals. Not just goals for the nation, for the state, but from that institution. We need to track, not just track mortality. We need to track everything, because then when we track also the process, we can improve. We need to report back, not just for the public, but for the clinician. So the people know exactly what they need to do differently. And also the leadership commitment, if you don't have the commitment, not just saying, oh, it's important, but telling the whole institution, this is a priority. Early detection and management of sepsis is a priority for our institution. We have this person who is the champion. We have this group who is going to work with you. That's the data. And we thought when I started working, I won't tell you how long ago, with healthcare-associated infections. I've been at CDC for 30 years, and I started even before that. People say, oh, this is something that we should expect from care. Until we're able to show, no, that's not. And guess what? It can be prevented. And that's what you need to do to prevent. And so we're using the same thing. Sepsis is not something that we should expect. It should be eliminated. And what do we do? And so this is really an important way of having elements. It's not just a checklist. It's really a commitment and we have specific tools to help people to start and to help people to really, the hospitals, to move forward. So it's, as I said, it's to provide guidance in monitoring and making really a great hospital management for the outcomes of sepsis. And with all these tools that it's like they're applicable to big hospitals, to small hospitals, and it complements existing sepsis guidelines. We should not say, oh, this guideline is better than this. We should adopt everything that will make some impact, like it was said in the presentation before. So that's the purpose. And I want to say that, first I want to thank Dr. Haley Prescott, who was our main person coming with her expertise. At CDC, we have expertise in many things, but she came and helped develop those elements. So they were not just elements that we were in a room in a federal government office thinking about. It was really based on everything that we are learning. And so we had hospital associations, patient representatives, all different groups as part of this, but not just to define what it was going to be, but to have their commitment. And we did a survey to assess how things were going on. And we did a survey using our national healthcare system network, NHSN, and about 5,000 hospitals. 73% said, it doesn't mean they have, that they have committee. However, when you go into the details, they don't have any person leading that. They don't have systems to track. It's a very small number of hospitals that do, and most of them are large hospitals, academic hospitals. But people are being treated everywhere. And we saw disparities being also a big issue that in New York. So we need to really see how to improve this, not just in the hospitals that are doing great, but in all the hospitals in the country. And also we say that these groups dealing with sepsis should work across other quality improvement groups in the organization, because it should not be a parallel thought. It should be integrated in care and all the quality improvement processes. So, as I said, we did this survey we published, and we hope to, not we hope, we are adding additional questions in 2014, more specific, because we don't want just to say, do you have a program? It's like, what level of program? And the goal is to have an idea of what hospitals are doing nationally, but also locally, and to attach that in the future with outcome measures that will look at sepsis mortality and everything. So it's like, we know that programs work, but are they really having a program that they say it's good, that is really having an impact? So it's a fantastic way to look at the impact of the programs and to promote the programs overall. So we learn also that we need to make a big splash every time we do things. It's not just me. I know you all love me, but it's not just me going to a place and talking. So we learned that involving the CDC director is a critical part. We were able to do that with Dr. Frieden, and we're able to do that with our new director. I think it was her first big press event, and she was very excited to do. We also learned that partnerships are critical, and not just saying you partner with, but showing you partner with. So I thought, American Hospital Association, the hospitals need to hear from the American Hospital Association. So we had also their CEO as part of the release, and we have family representation telling about the story. So we, it became a big event. And why do I care? I care because it's a way to people to remember again about sepsis. We forget everything. Right now, we're even forgetting how many people died of COVID. So we need to be reminded. We need to be reminded not just about the problems, but we need to be reminded about the actions and the commitment that we all need to take to really move forward. So I didn't know that. I'm glad my slide matched yours in terms of future opportunities. We work with CMS, and especially with CCSQ, like it's really siblings, and we get along. So we are working now together in how to really see the outcome measure. It's not to destroy what is there, but it's how we improve things. We are working with maternal sepsis, and because it's a big issue, and April knows that so well. Also, looking at the new estimates in pediatrics. Pediatrics is another piece that we are looking at really how to improve not just definitions, but capturing the data electronically so it can help us prevent things in the future. So, but what more is needed? I would tell you that, from my perspective, lots of progress, but what is needed is the cultural change in expectations and accountability. Research is critical, especially for the treatment, for early detection, but we need to change, and we need to remember the families and the faces and families are behind numbers. We need to remember that patients are at the center of everything we do, and that prevent, detect, and properly manage sepsis is everyone's responsibility. And I want to also highlight the importance of post-discharge management. We're seeing a big issue. We don't know the scope, but a big issue that is also being included in our core elements. So we need to really, each of us here and all of us here, we bring a different perspective, but those are the principles that we all should continue to have impact in each and every life today and always. Thank you.
Thank you, Denise. Dr. Klein, I think I have you up here next. So I've introduced Dr. Ron Klein previously from, I just heard the new initial, CSQ is what you refer internally, CSQ of CMS. I didn't have to spell out the whole thing, but Dr. Klein, do you have slides to show? Yeah. Absolutely. So if you wouldn't mind coming up and sharing your thoughts with us, please.
Thank you, everyone. So first off, thank you for welcoming me to the sepsis health policy world. Excuse me. I'm about a month into this. Spent 22 years as a pediatric hematologist oncologist before I came to Washington, D.C. in about 10 years ago as a Robert Wood Johnson Foundation Health Policy Fellow, and then worked CMMI, oncology, Office of Personnel Management, and most recently CCSQ and QIMVIG, which is a Quality Measurement and Value-Based Incentives Group. Excuse me for 1 second. Anyway, so although I'm new to the health policy world, at least in terms of sepsis, I should say, 22 years of watching children develop sepsis, watching too many children die of sepsis. So although I'm a baby when it comes to sepsis health policy, this is in my heart and my soul. So I'm happy to be talking with you today. I will show you this. I was trying to figure out what picture to put on my my introductory slide, and I moonlight as a pediatric emergency department physician at St. Agnes Hospital in Baltimore. And about a month after I started back at CCSQ in January, I was talking, an ER tech was helping me do some work, and I saw that badge, on her with her ID, and I said, "Wow, I want to take a picture of that." So that's a picture that the ER technicians and I think other ER physicians and people run around at Ascension Health, which is I think 120 hospitals in the country, basically carrying the SEP1 measures on their ID. And I'll talk about this later. And I'm a little bit cynical, but when hospital CEOs and hospital COOs and the chief medical officers start printing up badges and making people wear them, you know that you've gotten their attention. So that's why I love that badge. Okay, down is forward. So I have no financial disclosures. If you're a federal government employee, you can own no healthcare stocks. I was invited to a lovely dinner yesterday, but the federal employee, you can only accept $20 from any entity, so I decided to forego the dinner roll and butter and stayed home. And I should mention what Denise was mentioning, that this is a joint effort of CMS and CDC. We're working together, and actually, it's probably, I'm airing our dirty laundry a little bit. We all realized we were both working on sepsis separately. We said, wow, we should work together on this. And then, 6 months after the lawyers finished, working out the memorandum, the MOU, we started working together. So we're working together on this. So this is not really necessary for this organization, but this is my cranky doctor slide, meaning my cranky doctor in the audience slide, which is, why are you even measuring quality? What business does CMS have of measuring quality? Why are you doing this? Well, every successful organization measures the quality and safety of its products or services to remain successful. Every one. Tell me one that doesn't. Retail enterprises measure the quality of the products they purchase from manufacturers to ensure customer satisfaction. Customers comment on the quality of the products and services they purchase. That's common. You always look at the Amazon reviews before you buy a product on Amazon. If people are returning a lot of products to a retailer, they're not going to buy from that retailer anymore. Healthcare is no different. CMS is a payer of healthcare services to the tune of $1 trillion a year. So, and Americans are consumers of healthcare services. So we have every right, every reason, and a mandate to measure quality. But I know I don't need to mention that to this audience. And I realize there's a broad spectrum of people in this audience, so I apologize if this is a little bit preliminary. Take my slides back. So basically we have three ways of measuring quality. And this comes from Dr. Donna Bedian, which is a 1986 paper, but I think he started writing about this in the 50s and 60s. And he talked about structural measures. And those are the attributes of settings in which care is provided. This includes material and human resources and organizational structure. So do you have a structure? Do you have a protocol that does things? Do you have somebody dedicated to sepsis work in your office? If you're running a pediatric critical care program, do you have a pediatric intensivist on your staff? Just basic structural things. Sort of the next step in the process are process measures. And that's sort of what the SEP1 protocol is, which is what is actually done in providing and receiving care. So in this case, are the antibiotics being given? Is the blood culture being drawn? Is hypotension being treated? Those are process measures. Those are sort of intermediate. And then the last one are outcome measures. And outcome measures are basically how is the patient doing? How else is the patient doing? All right, there. I lost my job. It's okay. I might as well just keep talking now. Anyway, how is the patient doing? And it's the effective care on the health status of patients and populations. Now, and this sort of comes down back to the sort of cranky physician model of care, which is don't measure what I did, measure how my patients do. And so that's really, I think, the best way to measure quality. But then I know all of us who work in health policy quality, if we had a nickel for every physician who came to us and told us my patients are sicker, we'd be lying on a beach somewhere in a beautiful hotel drinking, I don't know, margaritas. There I am losing my job again. Anyway, so we're trying to develop outcome measures as really sort of what we consider the best way to measure quality, I think. But you can't always do that. So this is the SEP1 measure, which has been out there, I think, since 2015. It basically measures, are you measuring lactate? Are you getting blood cultures? Are you giving broad spectrum antibiotic fluid resuscitation, vasopressors if necessary, reassessing the patient? And this aligns with the Surviving Sepsis Campaign guidelines. And it was started, it's going to be moving. So right now, since I think 2015 or 16, it's existed in what's called the Inpatient Quality Reporting Program. So if you look at what you call IQR, if you look at Hospital Care Compare, the STAR system, how hospitals do on various things is in there. There's no money attached to this. This is public reporting of how they're doing. Starting in 2024, so very soon, we're going to move this to a payment program. And that's going to be the value-based purchasing program. So now there's actually going to be money at stake for hospitals in terms of how they do on the SEP1 measure. So, and I always say, let's see if that's the next one. Well, that's the SEP1 process bundle, which I think you're all familiar with, which we all talked about that. Recognize sepsis, treat hypotension, draw blood cultures, give antibiotics in a hurry, and do all those things. So this is a process measure, and this is going to be moved, as I said, it's going to be in both places. It's going to remain part of IQR, part of the Inpatient Quality Reporting Program, and it's also going to be tied to money, to payment. And so when we talk about, the question Orla asked me when we chatted about this, when she invited me to come, was what are you doing to increase emphasis on providing state-of-the-art care? Well, it sounds a little bit crass, but we're attaching money to it. And as much as I hate to say that, when you attach money to things in hospitals, people start to pay attention. So we're attaching money to it. SEP1 will also be a reporting program as well. And I always want to emphasize sort of the third bullet point there is that sometimes public reporting of quality metrics incentivizes change more than payments. So you may have realized that physicians are a fairly competitive lot. And I worked on the oncology care model for 5 years where we tried, at CMMI, where we tried to improve care in oncology. And one of the things we discovered when we spoke to our model participants was that the doctors cared more when you started publicly, not publicly reporting, when you started showing the doctors in the oncology care model how they are doing compared to their peers in the same practice, that motivated them more than another $1,000 or $2,000. Now, I'm the best doctor in this practice. How could I be fifth? So that's actually important too. So having both money and reporting, helps drive change. And coming back to this, I was so, like, I literally started at my job as CMS and I was working a shift in the ER. It's like, there's the ER tech and she's wearing that. I gotta take a picture right now. So again, for those of you who are cynical like I am, when hospitals start making badges and making people wear them, it means they care. It means they're paying attention. So we've gotten their attention. So is SEP1 changing hospital processes? And I think previous speaker mentioned they were about 50%, and I think now we're close to 60%. We started at 30. So, do we have a ways to go? Absolutely. Have we doubled what we were doing before? Absolutely. And also it's important to remember that these outcome measures, or these process measures, if you will, depend on you doing everything correctly. So if you miss even one step, you failed that measure. So that means 60% of hospitals right now are doing everything in the SEP1 measure. So I think, again, I'm a pediatric oncologist. I'm a glasses half full, rose-colored glasses kind of guy. And so I think that's pretty good doubling. Is there more to go? Absolutely. Here's some work from do the sepsis process measures actually have an impact on mortality? And here was some work that was published in 2022 that showed basically a 5.67% reduction in 30-day mortality, or 4.06% depending on which kind of propensity matching you did. So remember, that's not a 5% decrease in the value, that's an absolute decrease. So whatever 30% is goes down to 25%. That's, if you will, 1/6 improvement. What if that is 18% improvement? So it's important to measure. Remember that 5% means an absolute risk reduction. So in terms of actual decrease, it's a much greater number. Here is some New York State data, and I met some nice people from New York, so I'm hoping that I'm going to get data that's more current than 2019, which is the most recently published data. This thing called COVID happened in 2020, and I think they're a little behind on their data. I did call the New York State Department of Health, left them a voice message, have not gotten a return phone call yet, but I'm looking forward to knowing all these wonderful people from New York who are going to make sure that I get a phone call from the New York State Department of Health. But in just 4 years, they've had an 18% relative decrease in mortality. So I think I can't see the numbers from here. I think it's 26.1%, if I'm reading it right, or 28%, down to 23. So again, that's whatever that is, a 5.1% decrease. But compared to 28.1, that's an 18% decrease in mortality. That's 4 years. So I'm hoping that number continues to improve. I would tell you that CMS data, other people's data has shown that when COVID happened, health quality took a pretty big hit. And we can argue with the resiliency of healthcare systems. We can argue that there were so many things going on. Two people getting tied to one ventilator because there were not enough ventilators, not enough PPE. So there's a pretty big hit. We're now starting to recover from that from a patient safety standpoint. So hopefully those numbers will start to come up. But again, I think that's made a pretty significant difference. This also comes from the New York State report, and I'm not expecting to reach into each individual line, but the top bar are the best performers. So that horizontal line going across, that little black line, is basically observed minus expected. It's 1.0. So that's where you'd expect to be, or given all things being equal. So the best performers, you can see that they're below that 1.0 line, observed minus expected. You can see the middle performers cluster around that line, which is what you'd expect from middle performers. And you can see that the poor performers cluster above that line. So in terms of a policy perspective, the question you should ask yourself is, if we could make those worst performers, we have an 18% decrease over 4 years in sepsis. If we could just move those low performers up to the top performers, we'd have a much bigger increase. So maybe some of the focus has to be on those low performers and saying, what is it going to take you guys to improve? So this is, I think, my last slide here. So we are working together with CDC on an outcomes measure for sepsis. And again, that's where it comes down to that cranky doctor expression, which is, don't measure what processes I'm doing, measure how my patients are doing. My patients are doing great. So, okay, so we have to have an outcome measure. Now, the reason I put this slide up there, and it's not to litigate any particular detail of the effort, but was basically just sort of an epiphany that I had when I first came to government about 10 years ago, which is two doctors can have a conversation in the hospital hallway, and we can figure out if that patient has sepsis or not. That's easy. We can do that. That takes 30 seconds. But if you're CMS and you're looking at millions of claims and you have to figure out who has sepsis, that's much more complicated. And so I put this up there just because when people say, all right, well, an outcomes measure, what's the big deal? Well, it has to be risk adjusted, right? Because every hospital has sicker patients than everyone else. God, we've heard that enough. And we have to figure out how we're going to do that. So how do we define sepsis? There are ICD-10 codes. There's evidence of organ dysfunction. Did you use antibiotics? Potential other clinical parameters. For us versus CDC, or for us, Medicare matters because that's what we pay for. For CDC, all patients matter. So how do we do that? And what do we do? What time period do we look at? Is it just 30-day mortality versus in-hospital mortality? But then we have to add discharge to hospice. So one of the things that Earl and I were talking about when I first chatted is that I think the original JAMA article showed, I think, 275,000 deaths from hospice, deaths from sepsis, and now I think it's 350,000. So why is sepsis getting worse? Well, it depends how you count. So that original JAMA paper didn't count people who got discharged to hospice. It didn't count. It used, I think, coding to try to identify those patients, which is the best you can do when you're looking at hundreds of millions of claims, I guess. And so it probably wasn't as accurate, all-encompassing, and now it's getting better. So not sure that we're actually worse in terms of hospice measures. I keep saying hospice, sepsis measures. But we just have to accurately measure that. And that's sort of one of the conversations you always have in medicine, right, is when something is going up. Is it really going up, or is it just that you're better at capturing the data? And, one of the conversations we're having now is, do we include non-bacterial infections? Do we include, viral sepsis from COVID, from influenza, from RSV? And that's sort of a conversation that we're having. And then you have to account for hospital transfers. So when a community hospital transfers a septic patient to a tertiary care center, and that patient dies in a tertiary care hospital, it's not necessarily the responsibility of the tertiary care center. So how do we make sure we include all of those things? So again, no CDC folks were very, very concerned that I was going to get into the weeds on these topics and litigate all, what bilirubin and what creatinine with you, and that's not the purpose of this at all. That's just to basically say, when you say we want to look at outcome measures and they have to be risk adjusted, how much complexity there is, and we want to identify sepsis, how much complexity there really is. And with that, and the current status is under development with data testing of the various potential parameters and metrics. So working on that to try to figure it out. And my last slide, that's Whitefish Lake in Montana, where I did a PED CM onc locums back during COVID. So thank you, and I look forward to the discussion.
Thank you, Dr. Klein. I'm going to invite Dr. Valdez up here but comment just briefly on the impact of COVID coming up. Because COVID really confused a lot during that period of time, and some of what's gone on in New York is data stopped being submitted because people were overwhelmed, but it also really confused the area of where antibiotics were appropriate. And I think Dr. Silver and some of the others will comment on that later, but Dr. Valdez, thank you.
Thanks very much. May I have the next slide, please? Some of you may not be as familiar with the Agency for Healthcare Research and Quality as you are with our sister agencies, but AHRQ is one of the 4 science agencies in the Department of Health and Human Services, and we have a unique mission and obligation to the American public. We're the only agency that has as our mission the improvement of health care for all in our country. And by that, that's not to diminish the importance of the biomedical science that takes place at our sister agency at NIH and elsewhere, and CDC, but it also is a recognition that we need to focus on care, and particularly care for people who have sepsis and other kinds of conditions. We go about our work in 3 ways. We generate the science base that's necessary for understanding what needs to be done in improving care. We convert the body of evidence into actionable tools to actually assist in making that care better. And lastly, we have an obligation to look at and monitor the functioning of the healthcare systems across our country. Notice I say in plural because we don't have a single U.S. healthcare system. We have many healthcare systems in the United States. And so working with that reality is part of our effort at ARC to be to healthcare as CDC is to public health systems around the country. Next slide, please. When I took this position at ARC in the Biden administration, colleagues asked me this question. They noticed that life expectancy in the United States had been falling since around 2014, 2010, on a fairly steady basis. During a period of time during the public health emergency, we saw a dramatic drop in life expectancy. And people asked me, so what are you going to do about it? And the question and issue was, when we looked into it, or when I looked into it, a lot of this loss of life and life expectancy in our country was the result of preventable mortality. And a contributor of that preventable mortality, of course, is sepsis, as you've heard today. Next slide, please. The important thing about sepsis is that it's preventable and it's treatable, as you've heard from the previous speakers. But what we saw during the pandemic was a 50% increase in hospital-acquired infections and other kinds of patient and workforce safety issues. Sepsis was among those, and it was a major contributor of those activities. Thankfully, Senator Schumer and other leaders in Congress provided us enough resources to begin to attack this issue and to begin to re-examine this issue. Not that ARC had not been doing it for decades. We have. In fact, when I started my career in quality improvement in the 80s, 1 in 3 people died of sepsis. By the year 2000, when I started a school of public health in Philadelphia, we'd managed to bring that down to about 1 in 5 people dying from sepsis. The good news is that even though we've seen these increases most recently, we know that we've reached about, on average, 12% of people who have sepsis experience mortality. But that ranges dramatically from people who have their sepsis identified early to those who have their sepsis identified late. From about 5% mortality to, again, that 1 in 3 who have severe mortality, severe sepsis, die. And that variation needs to be narrowed, needs to be attacked, needs to be addressed. The other issue is this fact that we've also recognized that post-infections, so post-sepsis, is posing greater risk to survival beyond. And long COVID provides us an opportunity to begin to examine those issues of post-viral infections, which has an important lesson for post-sepsis infections, I think. Because, as was said earlier today, we don't really understand what's going on from a biomedical perspective. But we can't wait 20 years to figure that out. We need to provide care now for patients who have these conditions. Next slide, please. We had during the last budget appropriations, ARC was asked to do a real study on the burden of sepsis in America, both the personal burden and the financial burden that healthcare systems experience and that our society experiences. And so We're in the process of doing that study. We hope to have that study completed by the end of the year so that we can report back to Congress and look at future investments in what our colleagues at CDC are doing with their sepsis program, what CMS is doing with its payment program, because ARC provides the scientific basis upon which many of those programs at our sister agencies rely. While we were focusing initially on hospitals, because that's where the big focus has been historically, there's also a real recognition that our healthcare delivery system is highly fragmented and highly diverse today. Very different from what it was in the 1980s when people thought of going to the hospital or going to the clinic. Now there's post-hospital care and rehab. There's hospital at home. There is a whole variety of other kinds of care settings, and sepsis is there. And we need to be there to prevent it or to treat it. Next slide, please. ARC, as I said, engages in the science building, trying to address how we deal with sepsis. And these are just illustrations of a couple of the projects we were able to fund most recently as a result of the additional resources that we received from Congress. But in particular, what we do is we like to focus on taking a body of evidence and turning them into tools that people can actually use to improve care. Next slide, please. This is an example of one of those tools. It's called ARC's 4 Moments of Antibiotic, I think I'm getting help there, decision making. Because as you've heard from earlier speakers, early identification, rapid rehydration and other kinds of fluid activities to get cellular activity functioning and prevent organ dysfunction are required, but also the use and rapid recognition of the appropriate antibiotic treatment is necessary. And making the distinction among what antibiotics to use and when to use them is extremely important because of what was talked about earlier, our need to create a stewardship for antibiotic use so that we don't create antibiotic-resistant organisms. But we also created other toolkits to provide assistance to healthcare providers and metrics to begin to look at the safety of care. We've developed best practices tools, particularly for the acute care setting. And as I mentioned earlier, we're examining tools for care settings that are not in a hospital arrangement. Next slide, please. In November of last year, the Secretary met with the leaders of the 25 largest healthcare systems in the country to re-emphasize the need to rededicate ourselves, both at the government level and in partnership with healthcare systems around the country, to addressing patient and workforce safety issues, one of which, of course, and a major one, is sepsis. And so we've started down this line of creating a national action alliance for patient and workforce safety. And Dr. Gustin, I think this is in part what you're talking about, creating a national alliance, creating a national action that focuses on these kinds of issues that can be addressed in a public and private partnership. Working across the department, there's a rededication to patient safety and to workforce safety, two of the major safety issues that are really part of this preventable deaths that we see that are contributing to the loss of life expectancy in our nation. So as we gear up to do this public-private partnership, I encourage you to join this alliance, to join our work with CDC, with CMS, with HRSA and with all of the agencies across the department as we engage in a department-wide initiative to really focus on the issues of preventable infections, preventable harm, and in particular the kinds of preventable conditions that sepsis is and that the scourge that it is on our country. I want to thank you for taking on this effort, for the many years of dedication to your work. The progress that I described early on from the 80s to today would not be possible without our consumer advocates, without our patient advocates, without really the support that we receive from our communities that drive quality improvement in our healthcare systems. So thank you very much.
So if I can ask my panel to come back up and thank everybody for that. Dr. Klein, if you don't mind, I'm going to start with you. I really appreciate the work that you're doing at CMS in your first 2 months there, and really look forward to the next long stretch, hopefully. With the move of SEP 1 into a payment program, one of the controversies around SEP 1 from the front lines has been the all or none aspects of it, and that the weight of antibiotic decision making is similar to, I missed getting the repeat lactate on time. Any thoughts on any thoughts on that controversy, and to address the curmudgeon physician, I use a different term than you, who's sitting back and saying, you're judging me because I missed a little bit where I got the big things right.
We have that argument. We have that argument all the time at CMS. You know, I think there are various different composite measures like adult immunization status that I think have 4 or 5 different immunizations involved, and you have to do all of them to get the credit. I mean, I don't think that's a CMS program right now, but in general, we have those conversations. So it's pretty hard to take a measure that has various different elements and say, all right, this is 80% and this is 70%, this is 50%. Well, this is going to weigh more. So that's a pretty difficult, heavy lift. I think we'll echo here. I think the outcome measure, and that's the advantage of the outcome measure, is it will sort of be how did people do. Yeah, so I mean, I think that, I think curmudgeon physician, cranky physician, I think that, again, I'll sort of repeat what I said before, is that when you do health policy and you're talking about, I think, 140 million people that CMS covers between Medicare, Medicaid, and Marketplace, you have to do what works for 98% of people. Sometimes the 2% is imperfect, and my wonderful profession, God bless us all, we love to argue at the 2%, and that's something you learn in health policy.
Thank you. Foster, I may ask you to comment on that, but first I want to ask Dr. Cardo. You've patterned the new CDC sepsis hospital program on the largely successful, initiated a decade ago, CDC hospital antibiotic stewardship program. That's 10 years on, still work in progress. How do you see accelerating the work on sepsis given the importance of it, and maybe touch on the balance of antibiotic stewardship while we're simultaneously saying use aggressive broad spectrum antibiotics here for this life-threatening condition, regardless of what it does to stewardship?
So you're very consistent with your questions, because that was the first question you asked when we first met. How do you talk about, you're saying you were hurting sepsis. So that's the reason we changed a lot of things, and we said, no, you restart and then you reassess. So we changed the whole stewardship program to really address your comment at that time, extremely important. But what we've seen with the stewardship program was like, it was very difficult, different than healthcare associated infections, very difficult to have an outcome measure. And people were saying, so we cannot do anything. So that's the reason we thought about the core elements. And so when we started, it was 50% of people saying that they had something. We saw that small hospitals didn't have. So we worked with the federal agency that focus in small hospitals to have specific tools for small hospitals. And now we are around 80% of hospitals with programs. But not just saying that they have programs, we're also working with Joint Commission and experts to assess the quality of the programs. So I do see that it's not perfect. I never think that those programs will stop because it's always like improvement. But the work with CMS and the fact that all hospitals are, because of the work with CMS, all hospitals report to our NHSN and are required to do the survey. And then CMS, also we work together and saying that all hospitals had to have a stewardship program. And so it was the combination of having the core elements with a level of policy that require that, and accountability. If you don't have, you don't get the money you need. But I want to say that this is one step. It's not the solution for everything, but it's one step that we thought it would be a fantastic way to make sure that all hospitals will have a program, and every year even assessing the questions that are being addressed and working with ARC, like we did for even stewardship. We worked with ARC to say those specific hospitals may need tools for this and this, and ARC developed that. So I do feel that I don't think it's the main solution, but I think it's one step in moving to what we think is critical, because we saw that happen in New York. But I think the ideal is for us to have the outcome measures associated with this, because then you can really become a little bit more concrete. Are we saving lives or not?
Dr. Valdez, I see you wanting to say something, so please jump in.
I am going to jump in and just say that the question that you ask is precisely why ARC for Moments was created, a tool to help clinicians understand the complexities of making those decisions, both rapidly about providing antibiotic treatment, but also understanding the timing, because timing is important with this disease. The sooner that you get the identification, the sooner you get the treatment started, the sooner that you manage the issues, the more likely that people survive. And more importantly, the sooner that we better understand the post-infection issues, the better the life expectancy will be for people who've experienced sepsis.
Just want to say that's the type of work, the way we work together, because it's really looking at what the gaps are and then ARC developing those specific things. But I want to say one piece that I think is critical is that I've seen happening in hospitals is the discussion between experts that doesn't help the patient at all. So many infectious diseases will say, no, you cannot do this. And many intensivists will say, and look, we need to look at the patient. The patient is, and that's what we need to do. So I think it's a progress. You see progress, and we need to see how we make these things more mandate and really the standard of care everywhere.
As an intensivist for 30-some years, I'm thrilled to have you focus on the patients as a specific element. Dr. Geston, one of the things you highlighted was the flexibility that the Department of Health that you used to be a part of, I'll call that out, that you're not the entity that's not sharing data at this point in time.
Thank you.
But I know you know the people that are there, and we'll let them know that this is an opportunity for them to engage with their federal partners and to move this forward to a higher level. But you provided flexibility, so I'm going to come back to the question I asked Dr. Klein, is your thoughts on the lack of flexibility, and I don't mean that in a pejorative because it's simply to call out the difference of the federal program and the New York State program.
So, I guess the way I would answer that, Marty, it's an important question, is that I think that the more we invest in having better metrics and more metrics in sepsis beyond SEP1, the less we have to spend so much energy talking about the frailties of SEP1. And I think that the debate and all the controversy about it, and people have written articles, and I've written articles about it, they're not unimportant, but they miss the major point, which is that there's more to improving sepsis care and working on it, and more to measurement than the particular frailties of this measure. And I think the more we invest in it, the more distraction to some degree that there is. So that's part of why our push has been to continue to advance around core elements for the work that you heard Denise talk about, to continue to push CMS and others, measure developers, to work on an outcome measure. Again, I recognize all the challenges that Dr. Klein mentioned for doing an outcome measure, because we did it. So I know all those challenges. They're surmountable. They are clearly of a different nature at the federal level for CDC than they were at the state level. But we had all those challenges. We had all those issues. They remain, whether it's an outcome measure or process measure or any kind of measure. I think the major point is sort of move forward. Take a stab. It's not going to be perfect the first time. Clinicians and others are going to argue about whatever measure you do, no matter how you risk adjust it. I talked a little bit about the process that we used in terms of transparency and bringing in voices, including opposing voices. You're absolutely right. It's not going to make everybody happy on any particular day. I think the other corollary is, and you know this, hospital systems in New York and elsewhere use internal metrics to be able to look at how they're doing. And those, I would argue, are equally, maybe even more important in terms of moving the dial on this. So I skirted your question maybe a little bit, but
That's fine.
I did the best I could.
You provided insights which are critical here. Dr. Valdez, I see that you're ready to talk on this, and I really appreciate that, because I was going to bring this to you. This would seem to be one of the challenges for AHRQ, to be a leading entity in coming up with how we're going to understand what we're doing here.
Well, I think it's important to understand that when one develops metrics, this is a fine point, perhaps, or that is often not well recognized or understood. When you want to develop a metric for quality improvement, you're looking at a certain set of other characteristics, and New York did a great job of that. When you are, and I have a HCFA background, so I'm an old CMS, pedigree, so I have a health insurance background as well. When you want to pay for something, you have a whole different perspective of what you're looking for. And so when you develop metrics for payment systems or quality improvement systems, they're different. Simply adopting a quality improvement measure into a payment system isn't going to get the payment job done. And if you take the payment measure and you put it into the quality improvement piece, it's not going to get the job done. So I think we need to be real careful when we talk about metrics. What are the metrics for? What are you developing them for? What do you want them to do? At AHRQ, we want and focus on quality improvement and the improvement of care. But we also provide the science for our other stakeholders, that is CMS and private insurance companies and others. So we also look at those kinds of metrics. But I think we have to be real clear about what kinds of metrics we're talking about when you say metrics. Are you talking about quality and care improvement metrics? Or are you talking about metrics to make sure that healthcare providers are doing the things that we think lead to the best outcomes? And we pay for that.
So, not to introduce the next panel, because we've got a space in there. When we at Northwell worked with the IHI, one of the things that the sort of short of that was measures for improvement are not the same as measures for accountability. Payment is based upon accountability. You actually did something that justifies the payment. And those are in conflict. I mean, Dr. Silver is also here. Dr. Friedman's in the back. Work.
Hi, this is Belle Friedman from Northwell Health. What my question is, I know that outcome measures are really very important. Our challenge in New York, Dr. Destin was our chief, is that we get the mortality measures, the risk-adjusted mortality, over a year after it's happened. So we're looking at the past. And from looking at the hospitals and what they want to do in real time, we don't feel that's the best thing to do. So we still look at our process measures very closely. And we can keep that within a month or so, depending on the institution and how they collect their data there and how we do, the PDSAs on that, and in order to keep a tighter real time. So how soon would we be getting these outcome measures that we're supposed to be monitoring?
You're looking at me, so I'm going to respond because because quite honestly, as one of our previous speakers said, we actually have 3 different kinds of measures. We've got structural measures, we've got process measures, and we have outcome measures, which can be looked at in a variety of different ways and defined in a variety of different ways. And each of those can be defined in different ways. And we can't do just one or the other. We've got to do all of them. And quite honestly, real-time information and decision-making is what we're trying to focus on at ARC, which is how do we actually provide clinical support decision-making, and both not only to the clinician, but also for the patient who needs to be part of those decision-making process.
So I want to thank the panel. I could sit here and talk to you all day. This has been wonderful. I think next time we need to have a couple of hours just for this part of the conversation.